Good afternoon, everyone. This is Dr. Mohamed Nosair.
I'm Dr. Chatelain.
Welcome to the Montreal Heart. We have a very interesting case for you today. Can we have the slides, please? So we'll be talking about a calcified multivessel PCI in severe AS and cardiomyopathy. Next. This is let my colleague present the case.
So this is a patient, 82 years old patient, male patient, known for diabetes, hypertension, dyslipidemia, COPD, and he's having a dual chamber pacemaker. He has also a severe aortic stenosis with a mean gradient of 32 and an aortic valve area of 0.94 centimeters square. He's also known for a mixed cardiomyopathy with a reduced left ventricular ejection fraction. At the admission, he has normal blood test, and he was first referred for a pre-TAVI coronary angiogram.
So you can see the angiogram. It's a radial exam. You can see there's a lesion on the left main. There's a lesion on the diagonal. And if you look closely at the left main lesion, there's two nodules that are very significant. There's almost a CTO of the circumflex. Next slide. Very heavily calcified left system with tortuosity. And the right system, RCA is a CTO also. Next slide. So there was a heart team discussion, and the patient was surgically turned down and referred for a TAVI plus PCI. The syntax score was 42. Syntax score 2 is 62, with a 4-year mortality of 64 for either PCI or CABG. And the STS score was calculated, and it was 5% mortality. And the Euroscore 2 was 7.8%. Next slide. So the points of discussion here were, should we do the TAVI first and then the left main PCI, or should we do the PCI first with mechanical support following a aortic valvuloplasty, then the TAVI in third place? These were questions that are very important to ask, because either way things could go wrong. After discussion with the TAVI team and the heart team, we opted for TAVI first and then PCI. And actually the TAVI was done yesterday with an Edwards valve S3 Ultra 26. There were no complications during the procedure, and you can see on the image that the valve looks very well in place with the aortogram. And there was a transthoracic echo performed post-TAVI that showed an LVEF of 35%, a mean gradient 12, and an AVA of 2.3.
So the key points for today is to discuss about the options for management of calcified complex multivessel disease in a patient with a LV dysfunction and severe aortic stenosis, as well as to review the calcium management, specifically the calcified nodules, in context of a left main disease and bifurcation approach. We would like also to discuss the value of the right heart catheterism in high-risk PCI patient, and also finally the needs for LV support in freshly implanted TAVI patient.
So our plan today was to start off with the right heart cath. And the right heart cath, you want to extract the PAP pressure, systolic mainly, get the cardiac index, and also it's very useful to have a continuous PAP monitoring during the procedure. And using these values, you would determine if you need LV support or not. So today we did the right heart cath, and we had a systolic PAP of 30, and the cardiac index was 2.3. So usually my cutoff for putting an LV support would be 1.8. And in this case, especially that we have a freshly implanted aortic valve, we didn't want to go through the valve with a large impella for no good reason. So I think it's prudent to be able to perform the angioplasty without ventricular support and use pressors if need be. Our initial plan was to perform a radial approach, XB35, 7 French. Initially, we will see the images, but my plan was to perform left main circumflex orbital atherectomy followed by left main LAD orbital atherectomy, and use imaging for stenting and TAP technique for the circumflex for provisional LAD left main. That was the initial plan. But of course, usually when these kind of cases, they're very complex. And when you start the procedure, it doesn't always go as planned. And you need to be ready to change your plan according to how things are going. So we started off with a radial approach, but then we could not get beyond the elbow for various reasons. So we decided finally to perform a femoral approach for the angioplasty. And if you look at the angio, we'll show the angio images. So we know that they put on the right femoral a manta, and you know from the manta that there's a radio-opaque marker. You can usually perform access following just above the radio-opaque marker. So actually this access was I performed under fluoroscopy, where my needle was guided just above the radio-opaque marker. And you can see the access site, which is a pretty good access, and we can even close it afterwards with a perclose probably. Next. So upon cannulation of the left main, you can see the first image, there was significant ventricularization and drop of pressure. This for sure complicates things when you need to push and pull and perform atherectomy. So I had to be prudent during my injections. Next image. So I took an LAO cranial view, and here you can see the nodule of calcium in the left main, and you can see the nodule of calcium in the ostium of the LAD. And also you can see the diagonal, which is tortuous and calcified. It's almost a 2.5 vessel. So we had pre-discussions regarding atherectomy in this tortuosity. What would be the better choice? It was not very easy to choose because when you're dealing with a calcified nodule, usually better off with orbital atherectomy. I wanted to attain that diagonal, but with orbital atherectomy, the vessel size is limited, and because of tortuosity, it becomes risky. So after discussion with the specialist from CSI, we concluded that probably the diag would be better off treated medically. And I kind of agree with that opinion because it would be a lot of effort with risk, and the territory is not massive in such a sick patient. We have to put everything into perspective. Next image. So followingly, I crossed the, can we play the image? I crossed the CTO of the circumflex using a Fielder XTA and a Turnpike LP. I got into the distal lumen, and then I had to reevaluate my plan because I had, again, drop in blood pressure when I would cannulate with the XB. So I was debating, should I just pursue my plan and perform the atherectomy with this 90-degree angle and risk of having drop in pressure and maybe dissection at that site? Or should I just perform simple atherectomy, LAD left main, and keep it at that with possibly simple procedure, no complication, and good results finally? And after thinking, going back and forth and discussing with my colleague, we opted to keep it simple. Atherectomy, left main, LAD with imaging. So let's see the IVUS. So I wanted to perform IVUS first, but the IVUS would not go beyond that LAD lesion. So I took the images as I got them. So we'll show the IVUS images now of the left main nodule. So as you can see, can you show the IVUS, please?
Yeah.
So as you can see, we have a reference diameter of 4 by 4.3 that was measured, and we're getting now close to the ostium of the left main. You can see the calcium nodule protruding into the lumen and complete shadowing behind. So this is where we are now. I have my orbital atherectomy in place, and we're going to start working live. Let's have the live fluoro. So as you all know, the orbital atherectomy, there's only one size crown, which is the 125, and we're in place now. We're going on the live image.
Le flush, il a été remis.
So I'm going to come closely, prudently to the ostium of the left main because I know it's going to ventricularize and I don't want to have drop in pressure at this site. I'll advance a little bit the burr. And we're ready to go with the ostium. Here we go. So the technique with orbital atherectomy is to go very slowly and pull back. So you don't want to go quickly because you want to get as much sanding of the lumen as you can. And you use the sound as an indicator if you're obtaining good results or not. So here I hear resistance. So I'm going to hold back. And usually you should do 30 seconds run. Let's save this fluoroscopy. 30 seconds on, 30 seconds off. Luckily, the patient has a pacemaker, so we're not worried of bradycardia. And we don't need to do a separate access for a pacemaker. So we'll go again. Very slowly. And then you pull back. Advance millimeter per second, and then pull back. You want to avoid that spring and jump. As you can see, the hemodynamics are pretty good, but for sure my guiding is not selective in the left main. We're getting beyond that bend. And my plan is to do slow speed left main LAD. And once I have smooth runs into that mid LAD before that second curve, I'm going to go on high speed in the left main to be sure to sand that nodule. So go back again, slowly. So I'm having a little bit of difficulty going beyond the bend, but I'm letting the crown work its way through. I'm not pushing it. So I might miss some length. I'm going to advance the crown a bit into the guiding. There we go. No, I think I should have enough length to go through. So as you can see, this a pretty good curve in the LAD, but the crown is getting there slowly. There we go. We're taking that curve. Take your time, 1 millimeter per second. Come back. I want to sand that properly so we don't have issues. Hemodynamics stay stable. The PAP, we have continuous monitoring. We're at 20 of systolic. So I'll try to finish that run of the LAD. I'm going to avoid that second curve so I don't have to stent all the way there. And now I'm going to focus finally to finish off with the left main at high speed. So at least we can get a good sanding of that nodule. So the beauty of using orbital atherectomy is that you can do retrograde. So since we're dealing with an ostial left main, I don't want to start high speed in the guiding catheter. So I'm going to be decannulated and I will sand it retrogradely. So let's switch to high speed now. And I'll do it backwards. Try to go slow. Make sure to get that ostium. We'll go very slowly. I'm going to stop in the middle left main, make sure I decannulate and do another run retrograde. So now I'm pretty sure I'm decannulated. On high speed, and then I'm coming back. So I don't hear any resistance anymore in the left main. Pressures very well. Okay, I think this should do it for that. I will cannulate again so I don't lose position. Pressure, as you can see, slightly ventricularized, but it's a bit better than before. I think I'll take out my crown and I'll do an IVUS now. Okay, flow. Ouvre. If you can show my hands. No, wire's not moving. Coming back. Tell me when it's out, please. So this is a beautiful tool, the Glide Assist, in both bringing in the crown or taking it out, also delivering it beyond lesions or taking it out. Let's take a small shot. Good. Okay, let's see. So things look not bad. We're very close to the ostium. There's that nodule in the proximal main, nodule in the distal main, but there's no complications. The size is good. I think we can perform the IVUS now. I'll probably switch to a regular wire. Let's take the microcatheter, switch to regular wire because we're done with the orbital. So I rarely perform primary wiring with the Viper wire or the rotational atherectomy wire. It's just easier to maneuver a shorter wire. I always use microcatheters to deliver both and also to perform my angioplasty. Pousse. Okay, stop, fixed point. You can show my hands. There you go. So this is a 135 Turnpike LP. Delivering very beautifully to the distal LAD. Very good. Let's take out the wire. I'll take the run through, please. We'll prepare the indeflator. So I'd be very curious to see the IVUS image post-atherectomy. Okay. So I like to remove the microcatheters with Hydroglide. I put it on the indeflator and go to high pressure. And then it comes out beautifully on its own. No need for exchange length wires. There you go. Okay, let's perform the IVUS. So potentially I'm looking at the diag and I'm wondering, should I try to dilate with just with a balloon? It's still up for grabs. We'll see how the results look on IVUS before deciding. So we couldn't deliver the IVUS prior to atherectomy to this point. And now post-atherectomy, it's going very nicely. Let's have the IVUS image, please. Let's go on pullback. So that's the LAD reference diameter where I plan to stop. It's coming back. So we see fractures in the calcium here at 6. There's more fractures there in the calcium. Same thing in the calcified nodule midway. It's the circumflex ostium. Now we're getting to the left main distal nodule. Now we're getting to the proximal, and we see fractures in the calcium nodule down there. Stop the image. Can I see the left main ostium, please? Because we saw the that ostial nodule. Oh, I just montrer le Can we show the left main at the end of the left main, the last run of the left main? At the very end. No, more. Go further towards the ostium of the left main. That way. Let's see the ostium. Further. Go slowly here. Further. Further. Stop. So you see there's three sites of fracture of that nodule. So the only way to find out now is to inflate balloons. All right, let's take a 2.5 non-compliant, please. We'll see how that expands in the proximal LAD and left main. Can we have a measurement, please, on the landing zone of the LAD, the beginning of the IVUS run? Stop there. Let's take a measurement. And if you have difficulty delivering stents at this point, it's probably the angle, the calcium nodules coming out. So we will resort to guideliners and mother and child. Let's go to 14.
14.
Off. Can we have measurements of the IVUS, please, at the LAD? Go. At the very beginning of the run.
14.
Off. Go. Can we measure the beginning?
14.
Yeah. Measure. La mesure. Off. Go. 18.
18.
Off. So we have a measurement of 3.2 and 4.5 in the prox LAD. So I think we're safe to predilate with a 3.5. Can we have a balloon 3.5, 15 non-compliant, please? So I think I'm going to, after evaluating the image and the complexity of the diag with the calcium and the angle, and I still have significant angles on the LAD wire, I'm going to keep it simple. The patient went through the TAVI, things went good. I'm going to stay provisional, stay with my plan. I think it's very important to be able to adapt your plan to the situation, how things evolve while you're doing them. Because the optimal goal is to get the patient out with a good result and get him out alive, evidently. So this is a 3.5 non-compliant by 15. Good. So let's go here. 14.
14.
Excellent expansion off. Go. Off. Go.
14.
Off. Well, let's go in the ostium. Go. 18. Let's
18.
see how that looks. Looks pretty good. Off. So as you can see, once you're working in the left main, you need to maintain short inflations. just to maintain the hemodynamics. Should not forget, even if the valve is changed, we still have an EF of 35, and it's likely there's a good ischemic component. There's a CTO of the RCA and a circumflex. It's probably something that we'll discuss in the future if the everything evolves well. So I've had good expansion on my balloons. I think we're ready to stent. Let's take an image. So let's take a 3.5 by 24 stent to start. 3.5, 24 stent, please. And let's approach a guideliner just in case I have, or a guidezilla, in case we have resistance. Guideliner 5.5, please. The guideliner 5x5 is my favorite so far for assisted guide extension, because it really takes almost any vessel and you can deliver the stent easily.
Wait.
So in this kind of case, I prefer using high radial strength stents. Probably for the LAD, it should be okay. But for the left main, I will probably be considering a Megatron, because the high radial strength, and you can really take it up to good diameters. So let's see how the stent goes. If ever I need assistance in delivery, I'll use the guideliner. But I'll start first by taking a power position with my guiding, even if the pressure is a little bit ventricularized. Yeah, there you go. So yeah, no choice. I'm going to have to use the guideliner. Okay, let's take the 2.5 balloon again with the guideliner, and we'll deliver distally. And we'll do it that way. Pressure is ventricularized. We'll decannulate. So it's important to be very aware of what's going on with the pressure, even if we're not injecting, because in this kind of case, there's not much reserve. Guideliner. I usually like to deliver my guideliners over a balloon, because I find it it's much easier to deliver. It follows through the lumen of the vessel. So I came up to here, now I have resistance. Now I'll use the balloon to deliver to the rest. And you just inflate and follow it. It's a very common technique that we use in CTOs, inchworming. Are you a negative? Can I have a new 2.5 balloon, please? But it's an NC balloon, so I'm having difficulty crossing the back. Usually it's preferred to take a regular balloon, not an NC balloon, because it enters easier in the 5.5. It's not a large guideliner, and usually the transition in the back could be problematic. So for sure here we can wonder if how the case would have evolved differently had we done the PCI first and not the TAVI. And I think in this case it really demonstrates that it was probably the right choice doing the valve first. because I can only imagine the instability that would come. Doing this left main. Hold this like this. I'm having a little bit of difficulty getting behind the guide liner. So what you do in this case is that you just deliver both at the same time. Probably it's just a question of wires. There you go. So I'm delivering the balloon through the guide liner, and then I'll take them both together up, and that should resolve the issue. So there goes the balloon over the curve, and then we'll bring the guide liner right away after, and it should follow smoothly. Or it can increase your support. That's probably the calcium nodule. So then we can inflate to deflect from the calcium. Go, 12.
12.
Off. There you go. That's how you overcome it. It took the curve. There you go. I don't know if we caught this on. That's a very interesting demonstration of what calcified nodules can hinder. Go on there, 12. 14. Off. So let's get delivered the stent quickly. So don't forget, the guide liner is deep now. We have calcified nodules. Pressure is ventricularized. We don't want to be too ischemic in there. Of course, this is the kind of setting when if you have LV support, you don't need to worry much because things will be okay, but now we just have to act fast. And there goes the stent. So we'll deliver at this point. I'll take another, please. Go. A 4024, please. Vas-y, 12.
12.
Off. So back up the stent balloon. Optimize. Okay. Okay, we'll go 14.
14.
Off. So pressure is a bit low. We'll take out the guide liner, extubate. On va... Vous donnez 4 Denio, s'il te plaît. We'll let the patient recover. Take out that balloon. Sinon, on peut prendre un autre 3-5, 24. Pressure recovered nicely. You just need to let that left main breathe. We have a stent. So this is a 4.0. Need to keep in mind that we're using a 5.5 guide liner, so you can probably deliver the 4.0 through, but you won't be able to take out the balloon once it's used. So you'll have to take them both out. We'll see if I can deliver. I'll have to re-inchworm again. We'll see. Already tight in the guide liner. I'll take a good guiding position. No. Okay, there goes the guide liner. Okay, there goes the stent. We're good. Take out the guide liner. Do not inject. Okay, we're inside the other stent. We can go up now. Go up. 14.
14.
There you go. Excellent expansion. We'll take that on a cine off. Pressure is limited. So let the artery breathe. I'll have to take them both out. There it goes. All right. So knowing your material is key in these cases. You see them coming out both at the same time. Ventricularization. We'll let it breathe a bit. Let's stop a bit. Let the artery breathe. Let's take pressure to come up. Excellent. So I think we're ready to take one final stent for left main coverage, because we covered the distal left main with that last 4 stent. Maybe we'll take an image here, see what's going on. So diagonal is still there, circumflex is still there. We covered that curve. We're probably going to need to optimize, but I think we're ready to stent the left main. So let's take a 4.5 by 24 Megatron, please. So deploying ostial left main stents, it's important to properly choose your view to make sure you get a good look of that sinus origin. And I think we have a good view here. We see the Edwards valve, we see the origin of the cusp, and I think it's perfect landing. We also see that nodule. So we really, I think here it's safer bet is to protrude into the aorta, even 2 millimeters, just to make sure you get good coverage. So the plan at this point is to deploy the Megatron 4.5/24 and then perform IVUS and then optimize accordingly. But I don't think we have a ton of work left to do because the atherectomy well prepared the valve, the vessel. Okay, let's take a 4.0/24. So we don't have 4.5, but it doesn't matter because it's a Megatron, so it can go up to 5.5 easy. Let's get a 4.5 by 15 non-compliant balloon, please. You can also sometimes check in 2 cranial views to make sure you get that ostium, but I really think here we have a very good view. So Megatron is a really perfect stent when you're dealing with osteal lesions, either left main or RCA, as I said, for the radial strength, and also the first few MIs struts are separated. So if you need to deal with a bifurcation, it's easier to go through. There you go. That's beautiful. Okay, let's test here. I think that looks like a good landing. Let's take a cine on that. That's a good landing. So there's separation between the superior and inferior origin of the left main. I think if I maybe pull back 1 millimeter, I'll be midway between both, which would be an ideal position. I'll come back just a little bit. There you go. Check. Even if you have a bit of protrusion. Okay, I think that's perfect. Let's go there. So I'll take it to 18 here. 20.
20.
And down. Let's take the 4.5. So as you can see, every time we inflate, pressure goes down. Stop, let it breathe, and then go back up again. I'll do that. Let's go through the junction of 2 stents. I think I'll just use the new balloon. It'll be a better strategy.
Yeah.
And then we'll perform IVUS. We'll optimize that stent first, make sure we don't get any kind of crimping of the struts, and then we'll perform IVUS, see how things look. So that's the great thing of having initial IVUS measurements, because you know what limits you can set. Okay, let's go. Hold the wire. Let's prepare the IVUS. So, okay, let's go here to 8. Quickly and down. 8 and
8.
down. Down. So at 8 atmospheres in the distal main, we're 4.4. I think it's acceptable. Okay, let's go here to 14.
14.
Okay, so we don't find that calcium nodule anymore. It's gone. Off. Go. Let's go to 20 here. The ostium. Let's take a cine on that, see what it looks like. Beautiful. Off.
20.
IVUS. I think things are going to look good. All right. So one must wonder, had I spent all that effort and time doing the circumflex, complexifying the procedure, how much gain would there have been? Since things went really smooth, everything is stable for now. Sometimes we tend to do a lot of things, a lot of dilatations. There you go. And you wonder how much benefit comes from that when you complexify things. Okay, let's do the run back. Okay, we deliver maybe distally. Beautiful. There you go. Let's take a cine on that. And let's start the image. Is good. Let's go pull back. So we have very good stent expansion. There are no floating struts. Everything is opposed. Now we're in the proxial AD, coming back into the distal main. All struts are opposed. A little D-shaping here, but I think you cannot expect perfect round result with such calcified nodule. There's the bifurcation to the circ. Now we're getting into the left main. We'll see if the sizing is good. Everything is opposed. Now we'll see where I landed in that ostium. Perfect. So strut ends at the cusp. I don't think I could have hoped for better. All right, I don't think we need any more optimization. We're at 120 of dye. I think we'll just take some final shots and we'll call it a win for this gentleman. Take some shots. Bring back the wire. Let's go. Perfect. Count Simon Sank. So the diag is still in place. Circumflex is still there. And we have a really good result with the osteal stent. Perfect. Let's pull my wire and do a final discount. Beautiful. So that wraps up the case for today in my room. There's still one more very interesting case in room 1. So to conclude, I think heart team discussion with the TAVI team was crucial in getting the best outcome for this patient, doing the procedures the safest way possible. Doing the valve was the right thing to do at the beginning. And now I had a plan. My plan was complex, involved the bifurcation. I wanted to do everything. But then when it came time for procedure, I re-evaluated my plan and I readapted my plan according to the clinical situation going on. And I think we should all have a plan, but be flexible and willing to change. So it's been a pleasure working today and demonstrating this complex PCI. And thank you very much. And we'll just close the groin with perclose. Thank you.